Welcome back to Open Med School. The last session we have discussed about the major complications of cirrhosis of liver. And today we'll be discussing one among them, the HepatoRenal Syndrome. What is HepatoRenal Syndrome? HepatoRenal Syndrome is a functional renal failure that is occurring in advanced liver disease, that is usually in cirrhosis patients with ascites. It can occur in any acute liver failure also. So, HepatoRenal syndrome, as mentioned, is the development of renal failure in patients with advanced liver disease in the absence of another identifiable cause for kidney injury. Suppose this kidney is transplanted to another person with a structural disease, the kidney will survive. That is why it is called a functional renal failure. Now we go into the pathophysiology. What is the pathophysiology? The HepatoRenal syndrome is actually when there is a portal hypertension, there is development of splanchnic vasodilation due to nitric oxide. This will produce peripheral vasodilation. This will be recognized as decrease in the effective circulating volume and leads on to activation of renin, angiotensin aldosterone system and the sympathetic nervous system. That finally leads on to renal vasoconstriction and decrease in the glomerular filtration rate. So in the setting of peripheral vasodilation, you are getting renal vasoconstriction. That is the basic mechanism. So here, as per Harrison, portal hypertension leads to systemic and splanchnic vasodilation, causing relative hypovolemia, activating vasoconstrictive systems that impair renal perfusion. Hope this point is clear to you. So this is a simplified diagram showing portal hypertension. This leads on to splanchnic vasodilation, decrease in the effective circulating volume, activation of the sympathetic nervous system and the RAS, finally ending in renal vasoconstriction and development of HepatoRenal syndrome. Hope this point is clear. Now we look into what are the types of HepatoRenal syndrome. There are basically two types. One is HRS1 and other is HRS2. Let us look what is HRS1. HRS rapidly progresses over 2 weeks and the untreated mortality is very high, almost always. Triggers are alcohol, sepsis, so somebody with a spontaneous bacterial peritonitis or infection. Now, of course, the serum creatinine increases. HRS2 is slow in progression and it has got a better prognosis. So that is what you should know. So now the HRS is newer classification or newer nomenclature. HRS1 is now called HRS AKI. There is a rapid increase in the serum creatinine as mentioned by the spontaneous peritonitis, GA bleed, large volume paracentesis without albumin. So it has got a very bad prognosis. HRS2 is termed HRS CKD. It is a gradual renal dysfunction. Is also good. So this is the classification is by the newer International Club of Ascites ICA classification. The diagnosis of AKI according to ICA AKI criteria: increase in serum creatinine 0.3 milligram per deciliter over 48 hours, or increase in serum creatinine more than 50% from the baseline. Urine output less than 0.5 ml per kilogram per 6 hours. It is similar to the criteria for acute kidney injury. There is usually cirrhosis with ascites, absence of shock, and no current or recent nephrotoxic drugs like NSAIDs, many antibiotics, use of diuretics. Absence of parenchymal disease is a very important concept. No proteinuria, no hematuria, no urinary gas, normal kidney ultrasound. No complete response or no response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin 1 gram per kilogram body weight. So this is the definition is in align with the AKI definition. Now go to the clinical features. Already mentioned oliguria, low urine output, Urinary sodium is usually low, less than 10 milligrams per deciliter. The urine examination microscopy bland sediments that can be associated SVP, GA bleed, or large volume paracentesis. For the investigations we already mentioned, creatinine is rapidly rising, sodium is low in the urine, the cast, very important. Ultrasound shows normal kidneys. Now we go to the management. General management, discontinue the nephrotoxic drugs. Treat the precipitating cause. Volume expansion is essential. Now, a vasoconstrict therapy has come because we already mentioned that there is splanchnic vasodilation in the presence of peripheral vasodilation. So you go for a vasoconstrict therapy. Terlipressin plus albumin is the first line in many countries. Dose of terlipressin is 0.5 to 2 milligram IV to 6 hourly. Norepinephrine can be given as alternative. HepatoRenal is sometimes used along with the midodrine. So this chart shows the details. Those interested can go through the chart. Pause the video and write down. So the advanced options are, one is TIPS, that is transjugular intrahepatic portosystemic shunt. This improves renal perfusion but limited by encephalopathy. Liver transplantation is the definite treatment. And prognosis is poor with type 1. The median survival is less than 2 weeks. Early intervention and therapy improve outcomes. So in this session, the take-home messages are: high suspicion in cirrhosis patients with rising creatinine, rule out other causes of AKE, early use of vasoconstrictive therapy, and prepare for liver transplantation. So the questions and for the discussion: what are the key difference between HRS AKE and other causes of AKE? Why albumin is used? What are the indications for TIPS in HRS? Hope this session was useful to you. Stay tuned.